Okay, part 2 for week 4. Complications in pregnancy. We're going to talk about diabetes mellitus. As you know, it's a group of metabolic disorders characterized by hyperglycemia, resulting from a deficit or defect in insulin secretion, insulin action, or both, type 1 or type 2. But there are a couple other specific types, such as gestational diabetes. It's any degree of glucose intolerance with the onset or first recognition occurring during pregnancy. Women experiencing gestational diabetes should be reclassified 6 weeks or more after the pregnancy ends. And it's just like gestational hypertension. They may have had the condition prior to pregnancy, but it was undiagnosed. Pregestational diabetes, type 1 or type 2. Almost all women with pregestational diabetes are insulin dependent during pregnancy. Generally, the oral hypoglycemics are contraindicated in pregnancy. Insulin needs, this is really important. Insulin needs in the first trimester are less. There's better glycemic control in the first trimester, partially due to nausea and vomiting and decreased intake. Second and third trimesters, pregnancy exerts a diabetogenic effect, or a glucose-producing effect on maternal metabolic status. Maternal insulin requirements gradually increase from approximately 18 to 24 weeks to about 36 weeks. And they may double or quadruple by the end of the pregnancy. So close monitoring is really important for these women. Postpartum, they may return to normal during lactation, and during lactation, maternal insulin needs are low. Again, requires close monitoring. Preconception counseling are recommended for all women of reproductive age, whether or not they have diabetes. Optimal glycemic control preconception is associated with less perinatal mortality and few congenital anomalies. In fact, women who are controlled pre-gestation typically have no more risk for complications and abnormalities than a non-diabetic. Maternal risk and complications include poor glycemic control around the time of conception, and in the early weeks of pregnancy is associated with an increased incidence of miscarriage. Women with good glycemic control before conception are no more likely to miscarry than women who don't have diabetes. Poor glycemic control, however, in later pregnancy increases the rate of fetal macrosomia, or a birth weight more than 4,000 grams to 4,500 grams or bigger, an increased risk of shoulder dystocia. Often these women end up with cesarean sections, as demonstrated by personal experience with although she wasn't diagnosed diabetic, the fetal weight was 5,500 grams. Women with pre-existing diabetes are at risk for several obstetric and medical complications. Fetal and neonatal risk and complications include intrauterine fetal demise, IUFD, or stillbirth. It's a major concern. Hyperglycemia, ketoacidosis, congenital anomalies, infections, and maternal obesity are thought to be reasons for fetal death. Significant reasons. In the third trimester, fetal acidosis is the most likely cause of fetal death. Congenital malformations of the cardiovascular system, central nervous system, and skeletal system are quite common. In slide 46, you'll see pictures of a condition called sacral agenesis, where the lower half of the sacrum and below fail to develop or develop poorly. And this is almost exclusively seen with diabetes. The next condition is hyperemesis gravidarum. It's excessive vomiting enough to cause weight loss, electrolyte imbalance, nutritional deficiencies, and ketonuria. Usually begins in the first trimester, but about 10% of women continue to have symptoms throughout pregnancy. And it's associated with women who are nulliparous, have increased body weight, history of migraines, multiple gestation, gestational trophoblastic disease, or are carrying a fetus with a chromosomal abnormality such as triploidy or trisomy 21. In some cases, there's an interrelated psychological component. In personal experience, almost every case of hyperemesis gravidarum that I have cared for personally have had psychological concerns. Anything from previous history of rape or incest, physical abuse, ambiguous feelings about the pregnancy, family issues, that kind of thing. And psychotherapy or discussions with a psychiatrist or psychologist have proven very helpful. Complications from hyperemesis, as you can imagine, would be esophageal rupture and deficiencies of vitamin K and thiamine with resulting Wernicke's encephalopathy. So the complications can be quite severe. Maternal phenylketonuria, or PKU, is an inborn error of metabolism caused by autosomal recessive trait. Remember what that is? That creates a deficiency in the enzyme phenylalanine hydrolase and impairs the body's ability to metabolize the amino acid phenylalanine found in all protein foods. A special diet is followed indefinitely before conception and throughout pregnancy, and it's a recognized cause of mental retardation. As you remember, that's one of the 7 tests that are done, genetic metabolic tests that are done on the newborns. Slide number 50 is a PKU diet bullseye, and it has the best phenol-free foods that are included on a diet for a mom with PKU. There are some other metabolic disorders, thyroid disorders, hyperthyroid. It's rare in pregnancy. In most cases are caused by Graves' disease. Clinical manifestations include heat intolerance, diaphoresis, fatigue, anxiety, emotional lability, and tachycardia, as in non-pregnant women with hyperthyroidism. And treatment during pregnancy is drug therapy with PTU. Hypothyroidism occurs in 2 to 3 pregnancies per 1,000. Increased risk for miscarriage, preeclampsia, gestational hypertension, placental abruption, preterm birth, and stillbirth. Infants born to mothers with hypothyroidism may also be of low birth weight, and thyroid hormones are used to treat the hypothyroid, just as in a normal non-pregnant person. Cardiovascular disorders. About 1% of pregnancies are complicated by serious heart disease. A lot of these conditions are not known until pregnancy, with the extra demands put on it by the pregnancy itself. Perinatal mortality rate of up to 50% is anticipated with persistent cardiac decompensation. You should know the signs of cardiac decompensation. Classifications of organic heart disease. Class 1 is asymptomatic without limitation of physical activity. Class 2 is symptomatic with slight limitation of activity. Class 3, symptomatic with marked limitation of activity. And Class 4 is symptomatic with inability to carry on any physical activity without discomfort. So simply walking to the bathroom or doing ADLs can cause shortness of breath and difficulty breathing and that kind of thing. Congenital heart disease are things like septal defects, atrial septal, ventricular septal, and patent ductus arteriosus. Acyanotic lesions include coarctation of the aorta. Acquired cardiac disease, mitral valve stenosis, mitral valve prolapse, aortic stenosis. There can be ischemic heart disease, including myocardial infarction. Other related diseases are pulmonary hypertension, and that's pregnancy is contraindicated in women with pulmonary hypertension. I've only seen one case in my practice in 20 plus years. She did die after delivery, and it was found on autopsy that she did have pulmonary hypertension, and it was contraindicated for her to even be pregnant. Marfan syndrome, and I have some pictures of that. Infective endocarditis, Eisenmenger syndrome, peripartum cardiomyopathy, valve replacements, and heart transplantation. As you can imagine, all these conditions sort of pre or contraindicate pregnancy in most of these people. In slide 56, you'll see some pictures of some hands and a back of people with Marfan syndrome. You notice how long they are and how mobile the joints are. There's also a picture of a descending thoracic aortic aneurysm in somebody with Marfan's. This is typically how they die. Eventually, everything is just stretched and the aorta actually dissects and ruptures. Eisenmenger syndrome, on slide 57, there's a diagram with an atrial septal defect, ventricular septal defect, or complex defect, and it shows how it develops over time. 58 is an X-ray picture of an Eisenmenger syndrome with an enlarged heart. 59 is peripartum cardiomyopathy risk factors, and as you can see, PPCM, or peripartum cardiomyopathy, has several risk factors: high parity, high gravity, multifetal gestation, prolonged tocolysis, smoking, ethnic or socioeconomic factors, malnutrition, genetics, extremes of reproductive age, so less than 19 and over 40. And on slide number 60, there is a dramatic picture of peripheral gangrene from postpartum cardiomyopathy. This woman will probably lose both feet as a result of this related disease. Cardiovascular related disorders include management of cardiac conditions in pregnancy, minimize the stress on the heart, which is greatest between 28 and 32 weeks, and that's when the maternal blood volume is at its maximum. As you remember, it increases by up to 50% during the late second trimester. Signs and symptoms of cardiac decompensation. Take note. Subjective signs are increasing fatigue or difficulty breathing, or both, with the usual activities. Feeling of smothering, frequent cough, palpitations, feeling that her heart is racing. She has generalized edema with swelling of the face, feet, legs, and fingers. There are some objective signs: irregular, weak, rapid pulse, progressive generalized edema, crackles at the base of the lungs after 2 inspirations, and exhalations that do not clear after coughing. Orthopnea with increasing dyspnea, rapid respirations of 25 or greater, a moist frequent cough, cyanosis of lips and nail beds. You should note that CPR in the pregnant woman is a little bit different. She needs to have her uterus displaced laterally with a wedge, or put her in lateral position, which makes CPR a little more difficult, but it's really important if you're going to expect blood flow to return to the heart. You have to displace the uterus, otherwise the uterus will compress the abdominal aorta, the vena cava, and prevent blood return to the heart. Some other medical disorders in pregnancy include anemia, which results in the reduction of oxygen carrying capacity of blood. Iron deficiency anemia, most common kind in pregnancy. Serum ferritin levels of less than 12 micrograms per deciliter, and is treated with iron, as most pregnant women have. Folate deficiency anemia, most common cause of megaloblastic anemia, treated with folic acid. Sickle cell hemoglobinopathy is caused by the presence of abnormal hemoglobin in the blood. This is a genetic condition. Usually do well, but increased risk for preeclampsia, intrauterine fetal death, preterm birth, and low birth weight infants. And postpartum endometritis, increased risk for UTIs may be deficient in iron. It's caused by recessive, hereditary, familial hemolytic anemia that affects persons of African or Mediterranean ancestry, so not just Africans. Thalassemia. There's some pulmonary disorders: asthma, cystic fibrosis, and acute respiratory distress syndrome, or ARDS, that we'll get more into in the last week. Neurological disorders include epilepsy, multiple sclerosis, Bell's palsy. A couple of other autoimmune disorders that can be affected by pregnancy are systemic lupus erythematosus, or SLE, and myasthenia gravis. And finally, some GI or GU disorders like cholelithiasis and cholecystitis, not that uncommon in pregnancy. Inflammatory bowel disease can be exacerbated. Urinary tract infections are increased because of the inability to completely empty the bladder. Asymptomatic bacteriuria, cystitis, and pyelonephritis. Pyelonephritis can cause permanent urinary tract damage, including kidney damage. Okay, this is the end of part 2.